Welcome to the Deep Dive. Today we're tackling anxiety, getting into the weeds of the comprehensive clinical guidelines from the Dutch NHG-Standaard Angst.
Yeah, our mission here is to give you a fast track, basically, through the whole diagnostic process and the treatment options for anxiety complaints and the full-blown anxiety disorders in adults.
We want you to understand how doctors sort of differentiate, mild anxiety from a disorder that needs significant intervention.
And crucially, we need to cover the safety warnings, especially around medication. There's some really key points there.
Definitely. And we'll dig into something I found really striking. Just how often anxiety wears a disguise, showing up as purely physical symptoms. You might be chasing a non-existent heart problem when anxiety is the driver.
It's a huge issue. So let's start right at the beginning. The spectrum of anxiety. Normal anxiety first.
Right, the body's alarm system.
Exactly. It's that primal fight or flight kicking in when there's a genuine threat. Your sympathetic nervous system lights up.
So heart pounds, breathing gets shallow, thoughts race, I'm in danger. Totally normal if, say, a bus is heading your way.
Absolutely. Then there's the next step, what the guideline calls Angst-Klachten anxiety complaints.
Okay, so related to real-life stressors.
Yeah, often tied to big things, work pressure, family illness, maybe financial worries. They feel bad, obviously, but they tend to ease off when the situation changes or with some good information and just keeping an eye on things.
But when does it cross the line? Become, abnormal?
Well, it's a continuum. There's no exact cutoff point. But abnormal anxiety is defined by being way too intense for the situation, lasting much longer than it should, and happening even when the trigger is tiny or not even there.
And it starts messing with daily life.
That's the key. Significant interference with functioning.
And the classic, really intense example of this is the panic attack.
Indeed. A panic attack is this sudden surge of intense fear, peaking within about 10 minutes.
Not just fear, though. The physical side is overwhelming.
Oh, definitely. Choking feelings, chest pain, dizziness, this terrifying sense of losing control or dying, sometimes feeling detached, like derealization.
Yeah.
But here's the critical bit. A panic attack is a symptom. Like a fever, it tells you something's wrong, but it's not automatically an anxiety disorder in itself. It can show up in several.
Okay, that's a really important distinction, and it leads to this diagnostic gap you mentioned. Patients aren't usually walking in saying, I think I have Janae.
Almost never. There's often shame involved, or they think it's just their personality. Oh, I'm just really shy, when actually it's social phobia.
So they don't seek help for the anxiety itself.
Right, which is why the guideline really pushes clinicians.
Yeah.
Think anxiety if someone keeps coming back with vague, unexplained symptoms, frequent flyers, basically.
Okay, so let's talk red flags then. What specifically should make a clinician think, hang on, maybe this is anxiety?
Frequent visits are a big one, especially for complaints that shift around, often physical things with no clear medical cause, like persistent dizziness that checks out fine, or ongoing palpitations, muscle tension, trouble sleeping, poor concentration.
The anxiety is kind of speaking through the body.
Exactly. It's somatization. And the number here is just staggering.
Hit me with it.
Up to 76%, 3/4 of patients who actually have an anxiety or depressive disorder first show up complaining about physical symptoms.
76%. That's huge. They're convinced it's physical.
Totally. They're focused on their heart, their stomach, their head, getting tests done, while the real psychological root isn't getting addressed.
Which makes taking a good patient history, the anamnesis, absolutely vital. And the guideline had that interesting point about cultural context.
Yes, this is really crucial for good care, especially with patients from more collectivist cultures. Openly talking about negative feelings might be difficult, or even seen as inappropriate.
So the distress comes out physically instead.
Often, yes. It gets expressed as physical pain. The guideline materials sometimes mention the idea of soul pain. Asking directly, how do you feel emotionally, might just get a shutdown.
So how do you approach it?
The advice is an outside-in approach. Start with the external context. How's work? How's family life? Then ask more concrete things like, how does your family see this tension you're feeling? Or even, are you dreaming a lot lately? It gives an indirect route in.
That makes a lot of sense. More comfortable for the patient.
Exactly. And if clinicians need a tool to help sort through those messy symptoms, the four-dimensional complaint list, the 4DKL, is mentioned.
Right, that helps tease apart distress, depression, anxiety, and that somatization piece.
Yeah, it brings some structure to a potentially confusing picture.
Okay, let's map out the main anxiety disorders the guideline covers. It follows the standard DSM categories mostly, but includes PTSS and hypochondriasis too, because anxiety is so central there.
Right, so we've got panic disorder, which often leads to agoraphobia, then specific phobia, heights, spiders, that kind of thing, social phobia, GAD, generalized anxiety disorder, OCS, obsessive compulsive disorder, and PTSS and hypochondriasis.
What really jumped out at me was the age of onset for these. It's not uniform at all.
Not even close. It's quite fascinating. Specific phobias, they start super early. Median age is around 8 years old.
8. Wow.
Then social phobia, median onset is about 17. OCS tends to be later, sort of 22 to 36. Panic disorders, median hits around 33.
And GAD, that persistent worry.
That's generally the latest onset, median age is 40. Often emerges more in midlife.
That's surprising. You think of worry maybe starting earlier. What about how these play out long-term, the prognosis?
It varies a lot. Anxiety disorders often tend to be chronic, unfortunately. Panic disorder and GAD, for instance, often have this fluctuating course, periods of getting better, then getting worse again.
Any good news?
Well, specific phobias that start in childhood, a lot of those actually just disappear by the time people reach adulthood.
Okay, that's hopeful. But others can be persistent.
Yeah, hypochondriasis and PTSS, unfortunately, often stick around for a long time.
And we absolutely have to mention comorbidity when anxiety pairs up with depression.
Oh, that's a really bad combination. It makes everything worse. Symptoms are more severe, recovery is slower, the whole course tends to be more chronic.
And higher risk.
Significantly higher risk for things like psychiatric hospitalization and even suicide attempts. It's a serious clinical situation that needs urgent attention.
And the risk factors for developing an anxiety disorder in the first place. They got to echo what we've been saying.
They do. A prior history of anxiety or depression is a big one. Lower socioeconomic status, substance abuse issues, psychological trauma, and being one of those frequent visitors to the doctor's office, often with those physical complaints we talked about.
It all links together. Okay, let's shift to treatment. The model is stepped care. What's the philosophy there?
It's simple, really. Start with the least invasive treatment that has good evidence behind it. Only step up the intensity if the first step doesn't work well enough.
So, step 1 is?
Just education and advice. For many people with those anxiety complaints, simply understanding what's happening physiologically can be incredibly helpful. That plus monitoring.
And if it's a mild disorder?
Step 2 is often guided self-help, usually based on Cognitive Behavioural Therapy, CGT. Things like workbooks or online programs, maybe with some therapist support.
And for more severe cases, or if step 2 isn't enough?
Then you move to step 3, more intensive CGT, potentially medication or sometimes a combination of both.
Now, a core part of CGT, especially for phobias and panic, is exposure therapy. And the key advice seems counterintuitive. Don't avoid the fear.
That's the absolute crux of it. You have to gently guide the patient towards facing the anxiety-provoking situation or sensation. Avoidance just feeds the anxiety long-term.
Why? Why face the fear?
Because physiologically, intense anxiety can't last forever. It naturally starts to decrease after about 60 to 90 minutes, even if you do nothing but endure it.
Ah, so you ride it out.
You ride it out. And by doing that, the patient learns that the catastrophe they feared, dying, losing control, fainting, doesn't actually happen. That experience breaks the fear cycle. It's powerful.
But convincing someone to do that, someone terrified,
yeah.
That sounds incredibly difficult. Requires huge trust, right?
Absolutely. That therapeutic relationship is paramount. You can't just throw someone into exposure. This is where the cognitive part of CGT comes into.
Challenging the thoughts.
Exactly. Working on those anxious thoughts, especially what's called catastrophic interpreting, feeling a slight palpitation and instantly thinking heart attack. CGT helps reality test those thoughts.
And the behavioral part is the exposure itself.
Yes, exposure in vivo facing the real situation, and also response prevention.
What was response prevention?
That's about stopping the safety behaviors or rituals people use to try and reduce anxiety.
Like someone with OCS constantly washing their hands.
Precisely. Or checking the door lock repeatedly. Response prevention means they, say, touch the contaminated object and then resist the urge to wash. Or check the lock once, then sit with the intense anxiety that follows without checking again.
To learn that the feared outcome doesn't occur even without the ritual.
Exactly. They learn they can tolerate the anxiety and that the ritual isn't actually necessary for safety.
Okay, now here's that statistic that really made me pause.
Yeah.
About what makes therapy work.
Ah, yes, the non-specific factors. It's fascinating, isn't it?
It really is. Tell us about it.
Well, the research suggests that the specific techniques of therapy, the exposure methods, the cognitive restructuring account for maybe 15% of the outcome variance.
For only 15%. So what makes up the rest?
A much bigger chunk, around 30%, comes down to non-specific factors. Things like the quality of the relationship between the patient and therapist, empathy, instilling hope, just having a clear structure and rationale for treatment, being a supportive human presence.
Wow. So how you deliver the therapy is potentially twice as important as the specific technique you're using.
In terms of overall outcome, it seems that way. It really underscores the importance of the therapeutic alliance, the connection.
That's a profound point for anyone involved in care. Okay, let's move on to medication. What's the general approach, according to these guidelines?
For most anxiety disorders needing long-term medication, the first choice tends to be SSRIs, selective serotonin reuptake inhibitors.
Why of them over the older TCAs, the tricyclics?
Mainly because SSRIs generally have a simpler dosing schedule and, crucially, a lower risk of serious side effects if someone overdoses, plus often fewer day-to-day side effects for many people.
Are there exceptions? Like for one-off situations?
Yes, for situational performance anxiety, like major stage fright before a speech or an exam, a beta blocker like propranolol can be useful.
How does that work?
You take a low dose, maybe 10 to 40 milligrams, about half an hour to 2 hours beforehand. It doesn't stop the anxious thoughts, but it dampens the physical symptoms, the racing heart, the shaking hands, helps you get through the performance.
Okay. Now, the really big warning flag in the medication section was about SSRIs in young adults. This seems critical.
It absolutely is. The evidence is quite clear. For young adults aged 18 to 25, starting SSRIs is linked with a small but statistically significant increased risk of suicidal behavior. That includes thinking about it, planning, and actual attempts compared to placebo.
That's incredibly serious. So what are the mandatory precautions?
Extreme caution. First, start with half the usual adult dose. Second, assess suicide risk thoroughly before starting, maybe even get a psychiatric consult.
And close monitoring?
Essential. Frequent check-ins, ideally weekly for at least the first month. You need to watch very closely for any negative changes in mood or behavior.
That protocol sounds life-saving. What about benzodiazepines like diazepam or oxazepam? They work fast but have risks.
Right. Their use should be very limited. The guidelines say they're really only acceptable for a short period, maybe 2 to 4 weeks max, right at the start of SSRI treatment.
Why then?
Because SSRIs can sometimes briefly increase anxiety when you first start them. Benzos can help bridge that gap and manage those initial side effects. But long-term use is strongly discouraged.
Due to dependence.
Dependence is a major one, yes, but also increased fall risk, especially in older adults, and potential cognitive impairment with long-term use. They are not a long-term solution.
Okay, last point on meds.
Yeah.
Coming off them. Tapering.
Absolutely crucial. You don't just stop these medications abruptly. First, patients should generally stay on the medication for at least 6 to 12 months after their symptoms have fully resolved, after remission.
To prevent relapse.
Exactly. And when it is time to stop, it has to be done gradually, tapering the dose down slowly.
To avoid withdrawal symptoms.
Yes. The guideline uses the mnemonic FINISH to help remember common withdrawal effects.
Right, that's flu-like symptoms.
Insomnia, nausea, imbalance like dizziness, sensory disturbances like odd zapping sensations, and hyperarousal, agitation, anxiety.
FINISH. That's helpful. And some people need extra slow tapering.
Yes, especially if they were on a high dose, used it for a long time, or had withdrawal issues just from missing a dose. For them, the taper might need to be extremely gradual, potentially involving up to 9 small steps down in dosage over several months.
Wow. That requires patience and careful planning. Okay, that really covers the spectrum from diagnosis to treatment and safe medication use.
It's a lot to take in, but the structure is there.
Absolutely. So the key takeaways seem to be, look beyond just the physical symptoms for diagnosis. Really encourage patients to confront avoidance rather than flee from anxiety.
Using tools like CGT and exposure.
And make really informed, shared decisions about medication, being super careful with young adults, and always tapering gradually.
That sums it up well. And maybe one final thought to leave people mulling over.
Go for it.
We noted that generalized anxiety disorder, GAD, tends to have a later onset, often around age 40. Interestingly, it's also the most common type of anxiety disorder found in older adults over 65.
Huh. So that persistent, free-floating worry becomes more prevalent later in life.
It seems so. The question to ponder is, why might that particular type of anxiety become so common in later life? What factors might contribute? Something to think about.
Definitely food for thought. Thank you for walking us through all that.
My pleasure.
And thank you for joining us for this deep dive. We'll see you next time.